Okay, everyone, thank you so much for being here. It's just about noon, so we're going to get started. Welcome to the AHRQ Quality Indicators Software version 2023 release webinar. Before we really get started, we do have a couple of announcements for you. I just wanted to let everyone know that we are going to be recording this webinar for posting to the QI site at qualityindicators.arc.gov. And by staying with us, you are opting into the recording. And because we do have so many attendees, all of our participation lines are in listen-only mode, but that doesn't mean you can't ask questions. You can ask them at any time during the presentation, and we'll be answering them during the QA session. You ask your questions by using the chat feature that appears in the Zoom window. Just click chat and a window will pop out and you can enter your question right there. And if you have any technical difficulties during the presentation, you can reach out to Sam, and this is his email right here. Okay. So next up, we have our speakers for today. Jennifer Newberg, that's me. I'm a senior project manager for Pantheon. And then we have Judy George. She's the AHRQ program lead in the Center for Quality Improvement and Patient Safety at AHRQ. James Dowell, he's a researcher on the Hospital Quality Indicators Project at Mathematica. Veronica Hernandez is a data scientist for Pantheon. And finally, we have the project director for the QI project for Pantheon as well. So we'll just keep going to our agenda. This is what we're going to be doing today. We have an overview of the AHRQIs themselves, and then an overview of the software and the version 2023 improvements, fiscal year coding updates, indicator logic changes, population files, rate changes, and some user suggestions. We have some usability improvements, and specification changes for select QIs. We'll talk about resources for our existing modules and for our new beta software, Cloud QI. And then, of course, we have that QA session that we talked about. And now, as we get started, I'm going to turn it over to Judy George. Judy.
Thank you, Jennifer. It's my pleasure to briefly overview the AHRQ quality indicators to kick off today's webinar on the software release. Next slide, please, Jennifer. As many of you are aware, the origins of the AHRQ quality indicators arise from HCUP, the Healthcare Cost and Utilization Project. The quality indicators were originally developed at the request of state organizations and hospital associations as a quality improvement tool. The indicators were developed and tested using HCUP data from 47 states and evaluation methodologies developed by the AHRQ evidence-based practice centers. Next slide, please. With over 60 measures, the quality indicators have a broad applicability and require only administrative data for use. These quality indicators are actionable. For instance, users can dissect the indicator results and relate them back to individual patient records, allowing them to discern actual quality opportunities from data quality issues. The results can then be used to motivate, guide, and evaluate quality improvement initiatives. Next slide, please. The quality indicators have a broad set of users. These include hospitals and health systems, hospital associations, health plans, a variety of third-party users, including EHR and data analytic vendors, as well as nonprofit quality improvement organizations. States, federal agencies, and federal health systems are also users. The known use cases for the quality indicators also range quite broadly across quality improvement, performance measurement, and research. Next slide, please. AHRQ makes this quality indicator software publicly available free of charge so users may produce measures to identify opportunities for quality improvement with as few barriers as possible. Users input patient-level hospital-administered data to generate the quality indicator event rates. Those rates will output at the hospital level or geographic area level, depending on the specific quality indicator that's selected. Beyond generating observed event rates, the software also produces risk-adjusted rates, which are derived from the state-level HCUP data. Next slide, please. As part of AHRQ's commitment to continuously improve the quality indicators, annually we evaluate their scientific acceptability through a rigorous and comprehensive approach, which includes reviewing recent evidence through literature reviews, incorporating updates annually of diagnostic and procedural codes used in administrative data, empirically testing potential changes to the indicators as a result of those changes, while also considering input from clinical and measurement experts. AHRQ remains committed to complete transparency in these updates we make to the quality indicators, including the modeling processes and the source code used to generate the measures. Our website includes extensive documentation as evidence of that commitment. Most importantly, we rely upon you and your suggestions for software updates through your technical assistance requests. So please, I urge you to continue to submit your questions and suggestions to improve the quality indicators through those technical assistance requests. Next slide, please. As a quick refresher, the quality indicator software includes 4 modules representing inpatient care, patient safety, pediatric care, and preventive care. The inpatient quality indicators apply to adults and measure mortality, morbidity, utilization, and procedural volume. An example measure is heart failure mortality. The patient safety indicators focus on potentially avoidable in-hospital complications and adverse events. An example measure is death among surgical patients with serious treatable conditions. The pediatric quality indicators are hospital-based measures applicable to individuals under the age of 18, including neonates. These measures cover a wide range of conditions and potentially avoidable events, complications, or hospital admissions. An example measure is hospital admissions for asthma. The fourth module, the prevention quality indicators, measures hospital admissions for conditions where early intervention could potentially prevent complications or more severe disease. An example measure is inpatient admissions for short-term complications of diabetes. Next slide, please. I'm pleased to close this overview by drawing your attention to a new software module planned for release next month in beta version, the Emergency Department Prevention Quality Indicators. The new module aims to identify opportunities for which appropriate and timely ambulatory care may reduce the likelihood of emergency department use. The beta version will include 5 quality indicators measuring ED visits for non-traumatic dental conditions, asthma, back pain, as well as for chronic and acute ambulatory care sensitive conditions. So mark your calendars for that September beta release. The website will have more details, and please reach out to the AHRQ technical support team, whose email address is listed here, about questions related to that forthcoming module. So with that, I will hand it over to Jennifer, who will take us back to our focus for today, walking you through the updates to the software version released last week. Jennifer?
Okay. Thank you, Judy. This is our software release. This version, the 2023 version of the QI software, released on August 14th, and it's now fully available for our users. SaaS QI users can download the individual software packages for each module that they're interested in, and WinQI users download a single installer for all modules. As we identify new needs and refinements for all of our products, our technical specs are updated and posted annually, and we always provide a full suite of documentation every year for our platforms. And that includes software instruction, release notes, and everything you need to get started with the software. So that's just a quick look at the release, and I'm going to turn it over to James Dowell to keep us going. James?
Thank you, Jennifer. So like Jennifer said, in this section, we're going to walk through how we annually update and refine the software, and then also look a little bit at what impacts those changes have. Next slide, please. So each year we always start by updating the data and updating the code sets and updating the terminologies that we need in order to implement the logic for each of the QIs and also implement the risk adjustment. And a big part of that is first that we make the latest software version compatible with the hospital data all the way back from 2016, which is the ICD-10 transition, all the way to fiscal year 2022. So doing that includes updating things like ICD-10-CM PCS codes to make sure they're compatible across all the years, and updating the MSDRG codes. And that's important for you because we recommend using the latest software version for everything. So including looking at historic data or looking at trends across multiple years. So the compatibility is crucial because you can look at trends across multiple years from that single reference point. And then afterwards, we take in the data from HCUP's state inpatient databases, so the SID, to build our risk adjustment model and our reference population. And in previous software versions, we used one full calendar year of recent SID data. But for this year, instead, we used a combination of 2019 through 2021 SID data. And I'm going to discuss the rationale for that later in the presentation. Next slide, please. So after we've made those annual changes around compatibility and around updating the data used, we're also making a number of more version-specific changes. And for these changes, we have a process where we're working with our clinicians and we're working with our coding experts to design the changes and ensure they're clinically valid. And then we test them to make sure the impact's what we intended. And if they pass testing, they're implemented. So here are some of those changes for the latest version. In the previous two versions, we gave users an option to exclude COVID-19 discharges, but this is actually the first year we're defaulting to including them. And accompanying that, also the first year we're risk adjusting for COVID present on admission. And again, I'm going to explain all that more in a dedicated part on risk adjustment at the end. And then moving down for the area level indicators, this year we gave the option for risk adjustment models based on either 2019 or 2020 estimates. So you can have risk adjusted scores from either a pandemic period or a non-pandemic period. And then to learn more about any of this, you go to the links at the bottom of this slide. Those are version 2023 software release notes, and you can learn more details there. Next slide, please. So now I'm going to look at some more of those large cross-module changes, but I'll also zoom in further to look at changes we made this version to the logic for individual indicators or for smaller groups of indicators. So here we might be making changes to the criteria for when a discharge is included or excluded in a quality indicator's numerator or its denominator, for example. So the first change to note is because running the MSDRG grouper software has been challenging for a lot of users. This year, we replaced MDCs 14 and 15, which are two of the more ubiquitous ones in the indicator logic. We replaced them with new assignments that instead just directly use the diagnosis code lists from those MDCs. So you'll still need MDC as generated by the CMS MSDRG grouper software and using the best version, but this allows users to generate rates for HQIs that use MDCs 14 or 15 a bit more easily. And then for the inpatient quality indicators, no significant changes this year. But for the pediatric quality indicators, we have two of them to note. First is PDI-5, which is iatrogenic pneumothorax rate. We changed the denominator exclusion. So where it used to exclude principal diagnoses or secondary diagnoses POA of only post-procedural pneumothorax, we're now this year also excluding air leak and other non-traumatic pneumothorax codes. So that's the update. And then moving down for PDI-9, PDI-9's post-op respiratory failure rate. And for this one, we used to exclude all dementia POA, But now this year, we only exclude severe dementia POA, and that's to align with some fiscal year coding updates that make that differentiation. Next slide, please. So continuing to look at some changes for individual indicators here. In the prevention quality indicators, we expanded the numerators for our 3 diabetes measures. So now all those 3 measures also capture other specified diabetes mellitus. And then in the PSIs, couple significant changes. The largest of those is that we expanded PSI 8. So PSI 8 used to only capture in-hospital falls with a hip fracture, but the expanded version in version 2023, now it still captures in-hospital fall with hip fracture, but it also captures a broader list of other fall-related fractures. And we did this because the clinically accepted definitions for major fall-associated injuries, so the definition from National Quality Forum, for example, or the definition from National Database of Nursing Quality Indicators, those definitions, they aren't only looking at hip fracture falls, but they're looking at that broader set of fall-related fractures. So by aligning our measure with those standards, we want to support efforts in hospitals to track that wider list and then ultimately reduce the frequency of those events. And if you're interested in more details about the PSI 8 expansion, if you go to the software release notes link that I had on the other slide, on the landing page there, you'll see announcement materials for PSI 8 that talk about it more. And besides PSI 8, we also updated PSI 12, which is perioperative pulmonary embolism or deep vein thrombosis rate. And this year, we now exclude heparin-induced thrombocytopenia, and that's a serious heparin complication. And then lastly, for the PSIs, we also revised PSI 15. PSI 15 is accidental puncture or laceration rate. And we added site-specific logic this year to avoid some false positives that could come from subsequent operations that happen, but then aren't related to the prior accidental injury. So that's the update for PSI 15. Next slide, please. Okay, so now I'm going to go back and talk more about updates and nuances to the data. And the information the data has or doesn't have can vary for different states or for different years. And some of these differences have been in the data since previous versions, so we continue to account for them, but some are new to this year's version. So first, what's the same? Colorado and Hawaii don't have information for a patient's age and days, so those are excluded in certain cases. And then the same goes for some states not having sufficient procedure date info, and same goes for other states not having sufficient POA data. And we still exclude records missing MDC by default, like I mentioned before. We still exclude records missing procedure dates from PSI 15, which was APL rate, because that's needed to define it. And then the issue to note that's unique for version 2023, it relates to our using 3 years of data to do the risk adjustment and reference population instead of 1. So in the final year of data we use, the 2021 SID, only 28 states of data were ready during the window of time that we developed the software. So for that final year, just the 28 states. And again, in a few slides, when I discuss risk adjustment, I'm going to return to this and explain why we did that. Next slide, please. So now I'll talk a little bit more about the updates we make to the data for the area level indicators specifically. And this update that we make every year, it allows us to accurately define the denominators for the AQIs. So quick reminder from earlier in the presentation, for the hospital level indicators, denominator is the number of discharges that meet the criteria in a given hospital, for example. But for the area QIs, denominator is going to be the population of people that live in a given region. And to get those population numbers, we use census estimates. So our data for the 2010s and 2020s uses post-census estimates, meaning it takes the most recent census and then it estimates it forward from that. And our data for the 2000s uses inter-census estimates. Difference is it takes both the censuses at each end of the decade to estimate instead of just the one at the beginning. And the link at the bottom will talk more about those kinds of estimates for the area level QIs. Next slide, please. So we've changed some of the indicator logic, we've changed some of the software logic, and all of these things can impact the rates. that are output by the quality indicators. So how can we tell what those impacts are going to be for the new version? So the way we see is we take the same HCUP data and we run it through the old software version, and then we run it through the new software version to see what the difference is for the overall observed rates for the QIs across all the providers. So on this slide, positive percent means on balance, the QI rates go up. Negative percent means they go down. So first, we see noticeable decrease in PSI2, and that's expected because that's death rate in low mortality diagnosis related groups. So each year for that one, we update that list of DRGs based on observed mortality in the recent data. So some DRGs can come into the list and some DRGs can go out of the list based on if they end up above or below the low mortality threshold. And then for PSI3, which is pressure ulcer rate, we saw a decent increase, and that's from the revision to the numerator criteria. And then for a good group of PSIs in the middle bullet, no or very small changes. But then for PSI 8, the observed rates increased by over a factor 3. And that's totally expected. And it's because, like I mentioned before, it was expanded from just hip fractures to the broader list of fall-related fractures. So there are just many more instances of all those other cumulative kinds of fall-associated fractures compared to just hip fractures. So that's why the rate goes up. And then lastly, for PSI 15, which was APL rate, that decreased because of the revision I mentioned before to avoid certain kinds of false positives. Next slide, please. So we can also look at impact for the new version for some of the composite indicators. And given some of the big changes this year are for the PSIs, we're going to look at PSI 90. So PSI 90 is a composite indicator, and it's from 10 of the PSIs. And the way each indicator is weighted in PSI 90, so how important that indicator is based on part on their volume. So how many events of the QI occur. So for example, PSI 8 goes into PSI 90. And if PSI 8's volume goes up this year, all else equal, it'll be weighted more heavily in PSI 90. And we do see that this year, PSI's weight increased by over 3-fold, but that's still not a big change for PSI 90 overall, because PSI 8 was previously very lowly weighted in PSI 90. So even after the weight increases 3-fold, it still comprises less than 5% of PSI 90. And you'll see for PSI 15, we saw a moderate decrease, and it's very close to its change in observed rate from the previous slide. And it's a similar story too for the other parts of PSI 90. Next slide, please. Compared to the PSIs, the impacts we see in the other modules are smaller. IQIs in general, stable. The PQI benchmark rates and the area PDIs are a little lower than previous years because the rates in the reference population are just lower for 2020. And that's likely related to the public health emergency. So both from people avoiding the hospital in general and seeing actually lower incidence of some conditions like asthma in the data. And in the PDIs, some small changes that were due to the reference population changes or because of some of the more minor coding updates. Next slide, please. Okay, so now let's talk about our updates to the risk adjustment. So part of the changes we make to the risk adjustment models are things we do every year, like changing risk factors so they're in line with fiscal year updates. And we'll also make specific changes to the risk factor specs. So this year, one of those changes was for IQI 15's risk factors. And IQI 15 is acute myocardial infarction mortality rate. So in last year's version, IQI 15 risk adjusted for any NSTEMI code present on admission, but this year's version prioritizes STEMI, the higher risk classification. So if you had NSTEMI and STEMI codes on the same discharge, the risk adjustment now would classify it as that higher STEMI case. And besides IQI 15, the two big firsts this year are first that we're risk adjusting for COVID POA, like I mentioned before. And then to better accomplish that, we're using those 3 years of data for risk adjustment and for building a reference population instead of 1. And one reason the 3 years of data is important for modeling COVID in the risk adjustment is it allows us to better capture the different impacts COVID had at different time periods throughout the pandemic. So in particular, we now have quarterly COVID time interactions for 2020, for 2021. So now in a given quarter for those years, the risk adjustment is accounting for the effects of COVID specifically in that quarter. And that can be very important to model it, right? So think about how different COVID's impact was in hospitals in Q1 of 2020 versus Q2 of 2020, or versus Q1 of 2021. So you have different strains, you have the introduction of vaccines, you have treatment potentially evolving over time. So all those are potential differences. And now the risk adjustment accounts for COVID, but it also accounts for those differences. Next slide, please. So that's our overview of the software and some of those big changes. And with that, I'll hand it off to Veronica to talk some about the user-facing improvements.
Thanks, James. So as James says, we're going to jump into that impact of the software's usability, as well as or changes to that impact the software's usability, and as well as some improvements. Next slide, please. So first up is our user options and software updates. So there are 3 options that are different in version 2023, and these affect how risk adjustment related metrics are calculated. The first option is related to procedure dates, and it affects the IQI module specifically. So for IQI, we've added the PR day option for users to indicate whether procedure dates are available. Now, procedure dates are essential to creating categories used in risk adjustment of procedure-based IQIs. So therefore, the software will suppress risk-adjusted related metrics for procedure-based indicators whenever users have specified they cannot supply procedure dates. And this option works very similarly to PR day option already in PDI and PSI modules. The second option here is related to the handling of COVID-19 discharges. So as James walked us through, in prior versions of the software, when producing hospital level outcomes, users have had the option to exclude discharges with COVID-19. They can include all discharges, both with and without COVID, or include only those discharges with a COVID-19 diagnosis. So what's different in version 2023 is that the default option is now to include all discharges. And again, this is because the risk adjustment models now adjust for COVID-19 present on admission. So therefore, any risk adjusted related metrics are now calculated for users who opt to include all discharges, and the software will only calculate the observed rates for users who choose either one of the other 2 scenarios. And then lastly, we have a new option, RA year, and this is for area level indicators, which allows users to specify the data year of the risk adjustment parameters. So with version 2023, the software incorporates a reference population for area level indicators that's based on 2019 and 2020 data. With these 2 years of data, the risk adjustment models now allow us to account for year, as well as the interaction between year, age, and gender. So this option is going to allow users to select their preferred risk adjustment coefficients, and users can do that by either selecting 2019 for coefficients based on a reference population that precedes the public health emergency, or 2020 for coefficients that will include it. And next slide, please. So now we'll discuss some improvements made in version 2023, and we'd like to start off by highlighting some examples of user-suggested refinements to the QIs. In version 2023, James mentioned this earlier, PSI 12 now includes a user-suggested denominator exclusion for type 2 heparin-induced thrombocytopenia. We've also had users suggest updates to our code list to further align measures with their clinical intent. So this includes the addition of brachial plexus subclavian vessel release procedures to PSI 6 and PSI 5 denominator exclusions. It also includes the expansion of the denominator exclusion for PSI 10 post-op acute kidney injury with dialysis rate. So now we'll account for partial or complete nephrectomies for a solitary kidney or for certain renal transplant complications. Users also suggested the change we made, but that replaces the use of MDC 15 and 14 in the calculation of aerial indicators with the code sets based on their diagnoses. So this will again allow our users to calculate area level indicators without the need to run a specific grouping software. And again, these are all improvements that are a result of our user feedback. So please do continue to submit your feedback by reaching out to our technical support team. And with that, I will turn it over to Vivek to walk us through additional improvements.
Vivek, I think you're muted.
Thanks for letting me know.
Mhm.
So as part of our annual update process, changes are made in all our QI products. So WinQI also went through fiscal year 2023 coding updates and specification changes. So in the next few slides, we will talk about WinQI specific changes, the changes that you heard James and Veronica talk about. There are some impact on the user interface because of those, and we have made some of those adjustments to accommodate those. So we'll kind of walk you through some of these changes in WinQI. So in version 2023, there are some changes to the MDC option. In the previous version, that is in version 2022, based on your selection in the import process, the software deleted the discharges with missing MDCs. In version 2023, the MDC input function has been moved downstream and now sort of added as part of the rates generation process. So you can continue to select the same options you would select in 2022. However, the difference is that the records in your input file are not deleted anymore. Instead, depending on your selection, the software will use the exclusion rules to logically exclude those discharges with missing MDCs from denominator. And for this for select indicators that actually use those logic, right? Instead of deleting them. The records in your input data set will still be there for other indicators to consider for computation. Additionally, as you heard, we replaced MDC 14 and 15 with new diagnosis code set. This reduces the reliance on MDC values provided by the input file. So depending on the percentage of missing MDC values in your input file, you may see a variance in your rate between the prior version and the version 2023 software if you're using the same data file. As part of our development process, we perform rigorous testing to ensure that the results across products match 100%. In version 2023, we used HCUP's SID data as our test data set that included over 8 million total discharges from 2020 and 2021 year. We found no variance in the observed in the risk-adjusted rate between SAS-QI and WinQI in version 2023. The reports with details are on our test data and testing process can be accessed via the link on this slide. Next slide, please. One of the improvements added in WinQI 2023 is your ability to regenerate indicator rates without a need for you to import an input file. This is the scenario when you have already generated the rates but want to regenerate by selecting different generation options such as COVID-19 selection or MDC selection. In version 2022, you must import an input file to get the regeneration process enabled. We heard about these limitations from multiple users. And as a result, in version 2023, which now supports regeneration for rates without needing to repeat the import process. So additionally, the COVID-19 default selection, as Veronica mentioned, has been updated in version 2023. So unlike version 2022, by default, the records with COVID-19 diagnosis are not excluded, and the software now produces risk-adjusted rates with this selection. In version 2022, however, the default selection was to exclude COVID-19 discharges. So that's sort of a little distinction in version 2023. Next slide, please. So as we discussed briefly, beginning with version 2023 for PQIs and area level PDIs, WinQI allows users to select appropriate years of the risk adjustment model. This provides the risk adjusted score appropriate to either a pandemic period, which is 2020, or non-pandemic period. So based on your selection, the system will utilize appropriate risk adjustment estimates. So that's sort of a UI implication of that logical change, and you will see that on this in WinQI on one of these screens. Another improvement is that in version 2023, the hospital and area reports now display the report criteria selected by you. This helps you see how each criteria might have impacted the report, such as the suppression of risk adjusted rate, for example, in the report. These details are included in the exported copy as well, such as Excel or PDF. They are added as a header in the report, so you will have visibility of what you selected for generating those reports. So we hope you would find these improvements helpful. Next slide, please. All right, so these were some WinQI related improvements. We will now switch gears and talk about an exciting new software product, version 2023 Cloud QI Beta, PSI Beta. This tool represents the future of the Windows-based AHRQ software. AHRQ is beta testing this new platform, which is set to replace WinQI in the coming years. The software currently supports just the PSI indicators in this beta phase. That the term cloud in the product name indicates that the product is architecturally designed to be ready for hosting on your own secured cloud, as well as you can run it on a desktop as well. The installation process is straightforward. We have removed the dependency of SQL Server, so no SQL Server installation needed. Yay! Essentially, just double click the setup file to install the application. And the idea of being able to host it in your cloud is to be able to provide remote access to the software via browser. So essentially you can create a URL and provide that access to your users. So there is no need for us to for you to install multiple machines. One of the biggest improvement in this tool is to be able to receive and update future versions seamlessly. In other words, you will not need to uninstall and reinstall the app. Most fiscal year updates will be like downloading a file and switching to the latest version. And yes, you will be notified for those updates. The prior versions are also retained in the software and can be switched to those versions for calculations. So unlike WinQI, there are no need to run Cloud QI on multiple machines, and as multiple versions will be contained within the software. For example, in the current version 2023 beta, version 2022.0.1 version is also included, and you can use either of these versions based on your needs. So no need to uninstall and install different versions. Rest assured, Cloud QI produces the same exact results as WinQI 2023 and WinQI 2022.0.1, depending on which version you choose to use. This slide has a link to the location where you can download the software. It's on the website. A new appendix is also added in the software instruction document to highlight the differences between WinQI and Cloud QI, the installation process, and all that. Please use that for your easy reference. We also welcome your feedback on this new beta software. Please reach out to us at qisupport@ahrq.hhs.gov with your questions or feedback. Next, please. Last but not the least, we have made design improvements in the AHRQ website. The site navigation hasn't changed much, so you should be able to navigate seamlessly We hope that the new layout provides you a better experience. We have added animated links to provide visual feedback when you are interacting with them. We have updated the software page to make certain resources more prominent, such as software instruction documents. You will also find a new section for you to download the Cloud QI setup file, as I mentioned before. Please do explore the website and let us know your feedback. So with that, I'm going to hand it back to Jennifer.
Thanks, Vivek. So now we're going to take a look at some of the software resources that we have available for you. Right here, this is the PSI 08 expansion announcement that James was mentioning earlier. And all of these links here are on our website. And I know we had a couple of questions earlier in chat about where to find everything, and will these slides be available to users after the fact? And yes, they will. We'll have them posted on our website in probably about a week or so. So all of these links will be live and you can reach everything you need. You'll be able to find documents related to each module on that individual modules page. And you can always reach out to technical support here at QIsupport@arc.hhs.gov, or you can stop by and visit our FAQs beforehand. So those are some of the resources that we have available for you. So please do come by and visit the website and see what else we have. We do have a full suite of documentation available for all of our software, and everything is available for download. So with that, we're going to take some time for QA now. I know that a lot of you have submitted questions through chat already, but you can continue to do that by using the chat feature in the webinar menu. And just as a reminder, because we have so many attendees, participants will remain in listen-only mode. So that is the only way that we can actually get a question for you. And we do know that we probably won't have time to answer all questions, but we do review everything that we receive in the webinar. And we look at feedback from our users, and that in turn informs our communications in the future about the QIs. So let's take a look at some of the questions that we have so far. Diane Davis is asking, is the PSI 3 increase due to changes for PSI 3 in version 2022? I don't see any changes in the changelog for version 2023 as it relates to PSI 3. I'm going to ask Patrick to take this one.
I'm sorry, Jennifer, were you calling on me?
Yes, I was.
Okay. Hi, yes, this is Dr. Patrick Romano. I'm from University of California, Davis Health in Sacramento, and we support the Mathematica and AHRQ team related to the technical specifications. And yes, so the weights in PSI 90 reflect the relative prevalence of each of the component indicator events. So what we've seen, unfortunately, is that the incidence of PSI 3 increased, even though the specifications didn't change from version 2022 to version 2023. As we brought in data into the reference population from 2020 and 2021, and as we included patients with COVID in that reference population, we saw an increase in the incidence of that particular indicator relative to others. So if you look at the benchmark data tables that are available at the Quality Indicators website, for example, you'll see that the overall incidence of that indicator rose from 0.60 to 0.67 per 1,000 discharges. And so that weight increase reflects the impact of that. Unfortunately, a number of hospitals and reports have come out with increasing incidence of pressure ulcer during the COVID era.
Okay. Thank you, Patrick. Let's see what other questions we have. Karen Dorisala, and please forgive me if I'm pronouncing anyone's name incorrectly, is asking, we rely on Vizient for our AHRQ numbers. When do you think they'll be updating version 2023 at their end? We're unsure what updates Vizient is going to make to their platform, so we recommend that you ask them directly. Judy, do you have anything else that you'd like to add to that?
No, Jennifer, thank you.
Okay. Great. And then Geeta Patel is asking, so are the exclusions of HIT for PSI 12 applicable for January 2023 onwards or August 2023 onwards? Patrick, I'm going to ask you again to respond to this.
Yes, so that particular change reflected new ICD-10-CM codes that were introduced for fiscal year 2023, which started October 1st, 2022. So that effect would have begun October 1st, 2022.
Okay, thank you very much. And next up, we have Cheryl Manchinton, who is asking, are each of the PSI 90 weight changes due to volume weights instead of harm weights? Let's see. Alex, is this a question for you?
Yes, hi, this is Alex Bull from Mathematica. I can take this one. So Cheryl is correct. The PSI 90 weight change between version 2022 and version 2023 because of the volume weight component only. So the harm component was held consistent and the volumes were changed because of the relative distribution in the reference population.
Okay. Thank you, Alex. I am not sure that we have any other questions waiting. So if you have some other questions, if you have any questions that you were thinking about, please go ahead and ask them. And you have all of our experts here ready to give you an answer to whatever you need to know.
Would it be fair to add that I think we welcome comments as well as questions? So if anything that's been presented today just raises a thought that you'd like to comment on, feel free to do so.
Okay, we do have another question that someone has just asked. And they are asking, once the updates are released almost a year after they are applied, as in updated today, but applied back to October of 2022, is it possible that we will skip a year to get caught up?
Jennifer, I can take this one to start.
Okay, thanks.
So it's important to remember that the QI software is backward compatible. So the goal is to get the fiscal year coding updates when they occur right before the beginning of a fiscal year, incorporate them into the software and extend a release. But if you wanted to analyze data across fiscal years, you would then try to apply, or you should apply the most recent software version 2023. If that didn't capture the spirit of your question, put a revision in the chat.
Okay, thanks, Alex. Next up, we have a question from Amy Bippin, who is asking, this may not be the right forum, but we are aware that in Alabama, our COVID peaks hit a different timeline than in other parts of the country. Has anyone else noticed the correlation with your PSIs and the COVID peaks in your area versus that of what is excluded from nationally reported quality metrics? Patrick, this is the third one for you.
Yeah.
Oh, no.
Okay. Yeah, I can start and then hand it to Patrick.
Okay.
So, as you'll see in the risk adjustment models, is that there is a correlation between COVID and many of the PSIs. So, but I'll let Patrick elaborate more. I know that some of his work has gone a little bit deeper, but the risk models that that are embedded within the software do reflect that relationship. But Patrick, anything else to add?
Yes, so I think we do understand, of course, that the impact of COVID varied over time and varied across states. And so this is why we encourage people to use the risk adjustment models and to study the risk adjusted estimates, because those risk adjusted estimates reflect the impact of COVID in each model. And specifically what we found, not surprisingly, was that the impact of COVID was greater earlier in the pandemic. In other words, in the earlier time period in 2020, we knew less about how to treat the virus. And we saw that the impact of the virus on PSI rates was greater. As we got into 2021, we saw that hospitals became better at managing patients with COVID. The virus may have become less virulent, population immunity increased. And for all these reasons, we modeled what we call the interaction between the COVID effect and time. So what that means is that basically, if your peak was later in your state than in other states, we account for that in the risk adjusted estimates. So hopefully that addresses your question. Now, obviously, if you're looking at the crude or raw estimates, just the observed and the expected, you may see a lot of ups and downs that may reflect regional impacts of COVID.
Okay, thank you, Patrick. Next up, we have a question from Ying Yang, who is asking, how does the inclusion of COVID cases impact the QIs in general? And I'm going to let Alex answer this one.
Double muted myself. The best way to think about it is that COVID can have an impact on the numerators and denominators, or it can have an impact on risk adjustment. So last year, in version 2022, the default was to exclude discharges with the diagnosis of COVID. So that removed cases from numerators and denominators. And in general, it was reducing rates, mainly because there's a positive association between COVID and many of the PSIs. So what you're going to see then is the impact of including COVID will generally increase numerators and will increase denominators. However, because we're including it in the COVID as a risk factor in the risk adjustment model, then it's incorporating that risk. And then the way that the risk adjustment works is that it looks at the observed number of events over expected number of events. And so risk adjusted rates, they might look like they go up a bit, but for most hospitals, if they're looking at their observed to expected ratio, it's harder to predict the impact of including COVID. It might just be the same because we're incorporating and including the risk of COVID. So it really depends on, again, if you're looking at the numerator denominator versus the risk adjusted rate to understand the impact of including COVID back into the QI rates.
All right, Thank you, Alex. We have another question on deck, and this is from Angela Marsh, who asks, will PSI-4 ever be updated? It makes sense for elective admissions, but not for those that have emergency surgery within the first 2 days, as they are often extremely sick, or surgeries that are attempts to save a life. Patrick, would you like this one?
Sure. Yes, we have received such feedback, I think, from many stakeholders, and we are currently in the process of testing some potential changes to PSI-4 that would be substantive changes to the logic of the measure, but that's currently still in the testing phase. So it won't you won't see that in version 2023. Obviously, PSI-4 is a measure that is widely used, has been in wide use for a long time. So we have to proceed carefully and cautiously, and make sure that we understand fully the implications of various alternatives. But this work is well underway.
Okay, thanks again. We have another question from Erin Dunsing, and she wants to know, is there any consideration for removing osteoporotic codes and pathological fracture codes from the PSI 08 tech specs? They are not always related to traumas in hospital, but related to severe pathology rather.
Yeah, so this is a little bit tricky because, of course, many patients, osteoporosis is a very prevalent condition among older individuals, and many of the fractures that we see do occur in the setting of underlying osteoporosis. So the current specification does include osteoporotic fractures because that represents the majority of the fractures that are occurring in older patients. However, I don't believe that it includes cancer-related fractures, but we'll double check that.
Okay, thank you. Next up, we have a question from Ann Eichhorn. Will CMS be updating the version of PSIs they include in the hospital star metric? Patrick, would you like to answer this one?
I don't think that AHRQ is able to speak on behalf of CMS. So CMS follows its own process, and of course the agencies work closely together. Judy, did you want to address that? Anything further from AHRQ's perspective?
Thank you, Patrick. I appreciate the question so far. I do think that we would need to have CMS weigh in on that, but to let everyone know, CMS has been a part of the process. And can you just remind me, Patrick, for the HAC results that would be released, would that be using the version 2023 from the CMS perspective or version 2022?
The HAC-RP results that are currently with hospitals through the HSR process are still based on version 2022 specifications. So it would be the next version that would be released next year that would reflect the version 2023 updates. The star ratings are a separate process, but again, typically CMS is running a year behind AHRQ in the timing for implementing the updates. But of course, they're also doing so based on data that is a year old. So the data now are through June 2021. So they don't include the fiscal year 2023 period at all yet.
Thank you, Patrick.
Okay, thank you, Patrick, and thank you, Judy. unfortunately, that is all the time we have for QA today. We are just about at time. If we were unable to address your question today, we do encourage you to submit it to the RQI support team via the email that you see here. We address all submitted queries, and we like to get them because they also help us to plan for future communications. Thank you so much for joining us. We really appreciate it. And this concludes our webinar for today. Have a good afternoon or a good morning, wherever you are. Thank you.
Okay.